a very valuable presentation. And you spoke loud and clear, and we truly benefited from that deliverance. While the young would want to prove their might by beating the bug, conquering the bug, it takes wisdom acquired over the years to stop the problem at its root, that is prevention. Who better than the doyen of immunization to address this topic? I call upon Dr. Kashi sir to deliver his expertise on the prevention of pneumonias. Welcome, sir.
Yes, I have this thing over. It's not working, man.
Okay,
I think I'll do that.
That's for recording.
Oh, that's for recording. Okay. Okay. Thank you, Dr. Srilata. Hey, what about my... We all know that prevention is definitely better than cure. So if we know how to prevent pneumonias well, all this knowledge was acquired over the last 3 sessions may not really be very necessary. So let's pay attention to this. Okay. Today I'll be discussing a few vaccines: pneumococcal, influenza, pertussis, hib, measles, and RSV monoclonal antibodies. If you wonder how I'm going to do all this in 20 minutes, hold on and see how I'm going to do it. This is a picture of a study done between 2004 and 2006, published in 2008, which looked at the causes of hospitalized pneumonias, etiological factors. And what we notice over here is almost half were due to bacteria, of which 2/3 were due to pneumococcus and about 1/3 due to H. influenza. In fact, this study laid the foundation for the WHO recommendation that PCV should be introduced in all the countries of the world, including the low-income countries. Let's fast forward to 10 years. This was a study called the PERT study, which was published exactly 10 years later after extensive use of PCV and the hib vaccine, which looked at the causes of hospitalized pneumonias in children under 5 years, 7 countries, 4 in Africa, 3 in South Asia. And what was very surprising is 61% were due to viruses, of which 31% were due to RSV. Bacteria came down from 50% to less than 27%. Of this 27%, only 12% was the pneumococcus. So the vaccines have worked wonderfully well and changed the very spectrum of etiological spectrum of pneumonias. What was very surprising is almost 1.9 to 10% of acute pneumonias were tuberculous in origin. So tuberculosis is not essentially a chronic illness, it can present as an acute pneumonia. And if you look at the last bullet, 15 million cases of pneumonia requiring hospitalization could be prevented with improved coverage of existing vaccines. A very, very somber take-home messages from this particular study. So let's come to the first vaccine, the pneumococcal conjugate vaccine. There are a host of vaccines. We are very familiar till 15 valent MSD, which is probably now going to be introduced in our country. There's a Turgene biotech in our country also, which is formulated 15 valent with 2 and 12, different from the Merck vaccine. 20 will probably be introduced very soon in our country. We have the 23 valent, 24 and 31 valent is been in development. 24 valent, both GSK and an Indian BE vaccines are doing it, and 31 is also a vaccine. So we are going to see a lot of new and exciting things occurring in the field of pneumococcal vaccine prevention. Now, why did we go from 7 to 10 to 13 to 15 to 20, 21, 31, etc.? That was because the entire composition, serotype composition of each pneumococcal vaccine was based on surveillance data done in US, not in India, done in US. So PCV7 was based on the 7 commonest serotypes found in children below the age of 5 years. Following the introduction of PCV7, regular surveillance, serotype surveillance took place. What happened? It's refusing to move forward. Right, okay. I think wants me to stop here. I think. ಬಂತು ಹೋಯಿತು. Lot of hints I'm getting. Okay. So after PCV 7 was introduced, they looked at the prevailing serotypes and then came PCV 13, further seroprevalence studies, then PCV 15 and 20. Now we are arguing about serotype prevalence. Is 13 better, 14 better, 10 better? Our latest data is as old as 2017, 9 years old. And we know pneumococcal seroepidemiology changes constantly. So I think it's very futile to argue which is better or which is not. I mean, basically, any pneumococcal vaccine will cover at least 70%. If you have 5 serotypes, it will cover at least 7%, 70%. So we need to remember that when we argue about which is better. Now, how effective are these pneumococcal conjugate vaccines in preventing pneumonia? I'll talk only about pneumonia. I won't speak about AOM or IPD, etc. This was a large meta-analysis done, systemic review meta-analysis. What they found that hospitalized clinical pneumonia, less than 24%, the reduction was 17%, and between 2 and 5 years, it was 9%. If you look at hospitalized X-ray confirmed pneumonia, WHO has got certain criteria for radiological diagnosis of pneumonia, which correlates well with pneumococcal pneumonia. The reduction was 31% in less than 2 years and 24% in those between 2 and 5 years. Not 90% like IPD, but the numbers of pneumonia cases are so much more than IPD that this causes a very, very significant public health benefit. When they compared PCV 13 versus no vaccine, reduction was about 26%. When PCV 10, I'm talking about the GSK vaccine, was compared with no vaccine, the reduction was about 12%. Some little difference between the two vaccines. Now, almost all children get immunized with the pneumococcal vaccine, but children who are at high risk need something more than the PCVs that we are giving. So who are these high risk children? We have high risk and very high risk. High risk are generally immunocompetent and they require PCV 13 plus 1 dose of polysaccharide vaccine. Okay? Those who are at very high risk, that is those who are immunocompromised, those who had CSF leaks, and note nephrotic syndrome is also considered as very high risk. They require PCV 13 plus 2 doses of polysaccharide vaccines. So this is where the difference comes between high risk and very high risk. Right. Now in high risk situations, generally amongst the available vaccines, especially beyond the age of 5 years, only PCV 13 and PCV 23 is used. I specifically mentioned PCV 13 because here we want to give more coverage than any other lower valency vaccines. The minimum gap between PCV 13 and PPSV 23 is 8 weeks in high risk. In normal elderly population, it is 6 to 12 months. 8 weeks, there is going to be an interference, but it's a trade-off between protection and a little lesser immunogenicity that you may get, and the need for early protection.
Dr. Kashi,
Yeah.
once the PCV 20 is available with us, no?
Yes, once PCV 20 is available, this will all true, because the recommendation now is only PCV 20 and no need for the polysaccharide vaccine at all. And I think by next year, things will change. So don't concentrate too much on this slide. It just indicates that the number of doses of PCV 13 depends upon the number of doses they have received in the past plus the age of the particular child. Okay. One more very interesting thing is that when a viral infection occurs, it causes significant damage to the lungs, damaged epithelium. There's a dysregulated immune function produced locally by the virus and its components, and there's a modified microenvironment. And all these three contribute to increased incidence of bacterial infections in those who have had a viral respiratory infection. In fact, studies have shown that there's a very high incidence of bacterial infection during all the influenza epidemics. Now, how well does PCV work in this particular situation? PCV9 reduced hospital administration associated with seasonal influenza to the extent of 45%. PCV7 39 to 50%. South Africa 26%, and in Spain a 48% reduction in influenza associated hospitalization due to provision of the pneumococcal conjugate vaccine. So pneumococcal does not only prevent pneumococcal infection, it also reduces the morbidity and mortality associated with influenza and many other viral infections. Of course, the most studied is the influenza virus. Right. One slide about Hib. In fact, it was introduced much before PCV17, and studies had shown that clinical pneumonia was reduced by about 4%, clinical severe pneumonia by 6%, and radiological confirmed pneumonia by 18%. So much less than what PCV has done. Right. Now we come to influenza vaccines. Okay. Now the schedule we all know is 6 months to 8 completed years is 0.5 ml, 2 doses, 1 dose if they've already been primed in the past. Above 9 years, it's a single dose, and of course, we all know the dose is the same, 15 microgram or 0.5 ml for about 6 months of age. When should I vaccinate? Before the onset of peak influenza activity. Most parts of the country, it is April to June, what we are doing right now. Southern India tip, it is October, November, Chennai and the southernmost part of Kerala. North India, it will be November, December, because there is a higher, larger winter peak and a lower summer peak. Should we give Northern Hemisphere or Southern Hemisphere? The WHO classifies India under the Southern Hemisphere zone of transmission, although we are in the Northern Hemisphere. So it is better to use the Southern Hemisphere strains. But the bottom line is, when you are vaccinating a child, use the most recent strain. Don't look at the Southern Hemisphere or Northern Hemisphere strains. Right. Now, when the efficacy or effectiveness of influenza vaccine is being ascertained, it's a very difficult ball game because there are so many variants. What is the age? Younger the child, lesser is the immune response. A child above 4 years produces much higher of antibodies compared to a child who is 2 years. Immunocompetence, is there a match or mismatch? Mismatch sometimes is so severe that you have negative values for the efficacy of influenza vaccine. What is the specificity of the outcome that we are looking at? Is it something very specific like laboratory confirmed influenza, or is it more non-specific like an influenza-like illness or influenza-related hospital, etc.? But generally, most of the efficacy data has concentrated on laboratory confirmed influenza. The next slide shows you over 10 years, if you look at the efficacy in US, it has ranged from minus values to as high as 83%. So I think basically influenza vaccine in a particular year is a shot in the dark. We can never predict how useful it is going to be, but it is definitely useful. How useful is influenza vaccines in asthma? We give to all asthmatic children. This was a large systemic review and meta-analysis which showed that influenza vaccine prevented 59 to 78% of asthma attacks, which leads to either emergency room visits, hospitalizations. So for persons with asthma, influenza vaccine may be effective in both reducing influenza infections and asthma attacks. So definitely all asthmatics should receive the influenza vaccine. Something new, the latest influenza guidelines of CDC states that egg allergy is no longer a precaution nor a contraindication, and you need to give influenza like any other vaccines with any precaution that you take like any other vaccine. This is because you require a certain content of egg protein to initiate anaphylaxis. And only the yellow fever vaccine has content more than that. It's usually 2 microgram per ml. All influenza vaccines contain between 0.2 and 2. And clinically, they have not observed any anaphylaxis in allergic individuals who receive influenza vaccine. That is, the CDC has changed the recommendations now. So we can safely go ahead and give the influenza vaccine. So we are back to trivalent from quadrivalent. Why did this occur? The first influenza vaccine in the 1940s was a monovalent vaccine. Subsequently, we got the bivalent, which contained one influenza A and one influenza B, which was basically the Victoria strain. Then we had the trivalent. I think all of us are very familiar. For many, many years, we used the trivalent with two influenza A and one influenza B. Yamagata really not become a big issue. Then, in following the pandemic that we had, H1N1 pandemic, the Yamagata strain raised its head. So we started a quadrivalent. Now, post-COVID, there has been no isolates of the Yamagata strain. So if we drop it, what if it comes up again? See, the hardiness of an influenza virus depends upon its capacity to mutate and evade existing immunity. Yamagata strain is a hardy virus. It does not mutate so frequently. And with all these years of use, there is very established population immunity. So it is very, very unlikely that the Yamagata strain will recur again. Victoria came back, but I don't think this will happen with the Yamagata. That's the general opinion. Okay, now let's go to pertussis. Well, we have a very significant load of pertussis. Definitely the load has reduced very, very significantly since the use of the pertussis vaccine. With increased use, the incidence of pertussis came down. We are having a lot of outbreaks recently, reported mainly from the Western countries who have excellent surveillance mechanisms. Various reasons have been postulated, of which one of them is change over to the WP to AP. I am not going to deal with that. Just suffice to say that that issue is not settled. There are many things apart from the changeover which are responsible for the resurgence of pertussis. Generally, acellular, the pooled vaccine efficacy against laboratory proven clinical pertussis is around 84%, very narrow confidence interval, very reliable estimates. For WP, it is about 94. So definitely WP gives better protection against lab proven clinical pertussis. That's it. I'm not going to talk anything more about WP and AP. Okay. Any new developments in pertussis vaccines? There are two pertussis vaccines which are being used now. Now, if you see, the pertussis toxin is inactivated with formaldehyde. When you inactivate with formaldehyde, many immunogenic epitopes are destroyed. So it becomes less immunogenic. So what have they done? They have modified it by genetic methods, by removing certain genes. That does not alter the immunogenicity. And this was a vaccine called Pertagen and Boostagen. Pertagen is AP, small p, and Boostagen is something like Tdap, but with the genetically modified. This was a research product of a Thailand company called Bionet Asia. And now those vaccines are now USA approved also by US FDC for use above the age of 11 years. And if you look at these figures, you can see the antibody titers in the genetically modified and in the conventional ones. Antibody titers are almost 200 to 500 times higher. Higher antibody means longer protection. So definitely these vaccines are not available, but may be available very soon in our country. We must remember that pertussis is a mucosal illness. And for mucosal illness, the best way to prevent is give rise to sterilizing immunity right in the lungs. And that is what this new vaccine is all about. This is called BPZE1. This is again a genetically modified pertussis strain where pertussis toxin has been inactivated genetically. DNT, dermonephritic toxin, has been totally removed, and content of tracheal cytotoxin has been reduced. This is given intranasally, one single dose. In the phase 2, phase 1 study, it has shown good results of reducing the amount of virus excretion following a challenge with a wild type pertussis virus. Now this is now going to enter phase 3 studies, and if this is really successful, it's going to be a path breaker in prevention of pertussis. Right. Measles vaccine. Let's not forget the lowly measles vaccine. Please remember, 79% drop in measles cases since the use of the vaccine. It has prevented an estimated 20.3 million deaths since its inception. Remember that in measles, 56 to 86% of all measles deaths is related to pneumonia. A variety of bacterial co-infections is associated with measles pneumonia. And studies in India and Pakistan has shown that in India, the incidence of all ARI has reduced by about 15%, almost 30% in Pakistan. So it's a very, very huge public health impact of measles vaccine. Nothing more about measles. Now I come to the last part about RSV prevention. I think this is the new kid on the block. We are all very anxious. We know that it is very useful, but we are probably hesitant to use it because of the cost and certain uncertainties that are there regarding this vaccine. So the first molecule is nirsevimab. Nirsevimab is a monoclonal antibody which is targeting this antigenic site called theta. There are various antigenic sites. In fact, clesrovimab is targeting site 2, so different sites. Now, this nirsevimab has called what is called as a triple mutation, which is called as a YTE mutation. This imparts longevity to it. Palivizumab act only for 4 weeks, so you have to give every month for 5 months one dose. Here it is going to work for at least 6 months. Now the indications are indicated for all newborns, not just the high risk. These are the CDC recommendations. Less than 8 months, 50 milligram for those weighing less than 5 kgs. For those weighing more than 5, it's 100 milligram. 8 to 19 months is 200 microgram, 200 milligrams single dose. You give 200 milligrams together. Certain situations you give a second dose of nirsevimab, and that is generally for children with chronic lung disease, severe immunocompromised state, and children with cystic fibrosis. Okay, in these situations, you're going to give a second dose in the second RSV season. Mark my words, we are talking about RSV season because Western countries have well-defined RSV and influenza. Things are different in our country, so we cannot, blindly extrapolate those recommendations.
Better to give it at the time of discharge.
We will argue about that. Okay. Effectiveness, excellent. Data from USA, data from Spain, data from Chile. RSV related hospitalizations reduced by 75 to 90%. In fact, all cause LRT hospitalizations is reduced by about 2/3. So it's having a tremendous impact. Now we know that we are giving one dose. How long is the effect going to last? Now this was a study done in Connecticut in USA, where they gave the nirsevimab and followed the children over 3 influenza seasons. And what they found was, when you look at the milder manifestations like medically attended RSV, there's a significant drop in efficacy. If you look at RSV associated outpatient visits also, there is a significant drop. But if you look at the more severe endpoint like RSV associated hospitalization, there is a drop, but from 94% to 85%. So it's a non-significant drop. So even one dose is going to have a tremendous impact at least for about 3 years. Not a recommendation, but studies are showing that maybe things may change in the near future. Now we have nirsevimab, we have maternal RSV vaccination. How do they two compare to each other? Undoubtedly, there is data to show that nirsevimab is far more effective against all the clinical endpoints, mainly because the antibody titers are far higher with nirsevimab compared to the ones which are transferred through the placenta. They're also shorter lasting. Maternal RSV vaccination gives protection only for about 3 months, maybe up to 6 months, but nirsevimab probably may last for even more than a year also. Now let's come to tuberculosis. Very active pipeline. There are so many vaccines in phase 3, and I think all of you all know about VPM1002, the genetically modified, and the other one was the immune vac. These are the 2 Indian vaccines, one by Serum Institute and one by Cadila. We were eagerly waiting for the reports because VPM 1002 was, if successful, was supposed to replace BCG, but unfortunately both of them have fallen flat. The recently published data in 2026 has shown that VPM 1002 reduced all TB by only 21% with negative confidence intervals. Pulmonary TB 19, again it only was moderately effective against extrapulmonary tuberculosis. Now as far as immune vac is concerned, which is a live attenuated vaccine, again it fell flat. It did not work. So development of both these vaccines have now been given up. So what are we left with?
You stop?
Stop. When it fails the phase 3, what are you going to do? No. So
Full of PPM.
now we are left with TB vac, which is a genetically modified, like it is something like a BCG. It's a modified BCG. So the disadvantage of BCG is region of differentiation, highly immunogenic epitopes are absent. So in this genetic modification, they have retained those RDs and they expect much better results. Now this vaccine is now undergoing phase 3 studies in India by Bharat Biotech. Just recruitment has begun. The second one is GAM-TB-Vac, which is a recombinant fusion protein. This is being done by Gamaleya, Sputnik vaccine, COVID vaccine, the same company. Not much of data about it. And the last one, which is by GSK, which again is a very exciting vaccine, which is again a fusion protein M72 with AS01E. AS01E is the adjuvant which we have with Shingrix. Supposed to be very, very potent. So they are using this, and this same vaccine is now undergoing in the phase 2 trial. It's shown an efficacy of 51%. Not great, but enough to come over to the phase 3 trial. So phase 3 trial of these tuberculosis vaccines are now underway, and hope at least one of these 3 should succeed. Okay. We have all talked about vaccines. The topic was about prevention of pneumonia, and not just prevention of pneumonia with vaccines. So, exclusive breastfeeding for 6 months, 23% reduction in pneumonia. Okay. Better nutrition for the first 2 years of life, 6% reduction in all-cause deaths, including pneumonia and diarrhea. Protection from indoor air pollution, even halving, you reduce the exposure by half, there was a 33% reduction in pneumonia. So if you reduce by 75%, 90%, this is going to be much, much higher. Okay. Improving the quality of primary care, including oxygen therapy, 29 to 45% reduction in case fatality. And if you treat and identify comorbidities, it will go a still longer way in managing pneumonia. So one should not forget non-vaccine study. Remember, most of the illnesses started reducing in intensity long before the corresponding vaccines came. Not just this, even pertussis, many other illnesses, it began with many measures which were non-pharmaceutical, and ultimately the vaccines caused the drop to be much more steep. So with that, thank you. Any questions, I'll be happy to take it. Thank you.
Thank you, Dr. Kashi, sir.